Take a moment and look around the room. Notice the faces, the colors, the way the lights move across the walls. For most of us, seeing feels effortless, automatic, like something we can count on. But what if I told you that in a slightly different version of this world, some of you wouldn't be able to see any of this? Not because of an accident, not because of genetics, but because of where you live, because of your zip code. I'm an ophthalmologist and I've spent my life caring for vision. And what I've learned both clinically and through research is that eyesight isn't determined only by biology and medicine. It's shaped by systems, by access, by income, by whether care arrives early or far too late. In fact, research now confirms what many clinicians have long suspected. An analysis published in JAMA Ophthalmology in 2024 looked at over 70,000 census tracts across the US and found that neighborhood level factors, things like income inequality, residential segregation, and persistent poverty, were strongly associated with higher rates of vision difficulty and blindness. In other words, where you live can predict whether you'll lose your eyesight. Another 2024 study looked at eye care access by zip code and found that for every 1% increase in the population with a college degree, the number of eye care professionals in that area also increased. While for every 1% increase in unemployment, access dropped. This isn't coincidence, it's structure. In public health, we call the non-medical factors that contribute to health outcomes social determinants of health, but that phrase, it can seem abstract, so I like to think of it a different way. Health isn't about the seed, it's about the soil. You can have good genetics, you can have effective medicine, you can even have excellent doctors, but if the soil is depleted, if the environment makes care inaccessible, then often the outcomes are predetermined. Research indicates that medical care alone accounts for only about 20% of outcomes. The rest is shaped by social determinants of health, things like housing, education, transportation, access to nutritious food, and access to care. I saw that divide clearly during my ophthalmology residency training in New York, when I trained at two hospitals that were only about 30 miles apart. One was in Westchester County, consistently ranked one of the most expensive areas to live in the US. The hospital was well-resourced, well-staffed. Patients arrived early in the course of the disease. They had insurance. They understood their diagnoses. They had the flexibility to take time off to come for an appointment or for a follow-up. The other hospital was in East Harlem, also known as El Barrio, one of New York City's most impoverished areas. Same doctors, same medical knowledge, same training, radically different outcomes. And that difference became heartbreakingly real to me one winter morning when I met Maria. Maria sat in the waiting room of the eye clinic at the hospital in East Harlem, holding tightly to her teenage son's arm. When I called her name, he stood first and gently guided her toward me. The night before, she'd experienced sudden vision changes in her right eye, which she said was her good eye. Speaking in the best medical Spanish I could, I learned that she was a single mother of two working multiple jobs around the clock just to keep them afloat. She was only 40 years old. She noticed some vision changes recently and thought she just needed some new glasses, but couldn't afford the time or money for an appointment. The night before, while cooking, she saw some sparks and then a shower of dark spots. By the time she awoke the next morning, a solid curtain had descended over her vision. Panic brought her to the ER, resulting in the urgent clinic referral to me. When I examined her, I saw what she couldn't. She had advanced diabetic retinopathy. The vision loss in both eyes was nearly total. Damage caused from years of uncontrolled diabetes, the type that develops slowly, the type that's preventable with early screening and timely treatment. But Maria hadn't had access to that care, not because she didn't care, but because the system made consistent care nearly impossible. And by the time she saw me, there wasn't anything I could do to restore her vision. And here's the part that haunts me. Over 90% of vision loss from diabetes is preventable, yet it remains the leading cause of blindness in working age adults in the US. Maria didn't lose her vision because medicine failed. She lost it because help arrived too late. That day forced me to confront an uncomfortable truth. I wasn't failing my patients, the system was. At the hospital in Westchester, patients with diabetes were screened early. At the hospital in East Harlem, patients often arrived only when their vision was already gone. The disease was the same, the difference was access. That realization stood with me, and I went on to practice ophthalmology for 7 more years. I love my patients. I valued the intimacy of one-on-one care, but I couldn't ignore the patterns I kept seeing. I was treating the consequences of inequity over and over again without treating its root causes. And I began to ask myself a hard question. If I can help one patient at a time in the exam room, how many patients am I failing tomorrow by leaving the system unchanged? That question led me upstream. I decided to move into biotech and medical affairs at Regeneron. In medical affairs, we bring in the voices of patients and physicians to shape drug development and help transform science into medicine. We connect data with real-world clinical care, helping to ensure that the right medicine reaches the right patient. Upstream work is about developing therapies that last longer so that patients can get the drugs they need. We use data, connect real-world clinical care with outcomes. This isn't abstract work. It's about changing the conditions that determine whether someone like Maria ever loses vision in the first place. In medical affairs, I'm passionate about advancing health equity in ophthalmology. Here's how we do it. We start by mapping gaps in access and outcomes, and then we share those insights widely with healthcare systems, advocates, and researchers. From there, we focus on real actionable solutions. And we partner with patient advocacy groups and medical societies to make an impact together. We're also holding a diabetes and eye care health education initiative where Regeneron colleagues go into communities to help meet patients where they are at community centers. We're also spearheading an ophthalmology health equity challenge, rallying innovators to develop solutions that both address and uncover barriers to eye care so that we can make a bigger impact. And I want us to take one more look around the room. Look at your colleagues. Look at us all here today because we want to build a better world. It's a beautiful sight. And I invite us all to ask this question. Who gets to determine who gets to see easily and why? And what would it look like to build a world where vision is protected long before it's at risk? Thank you.